Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, welcome back Francisco Torres, an interventional physiatrist, and he co-wrote the Kevin MD article, Radiofrequency Ablation and the Young Back Pain Patient. Francisco, welcome back to the show.
But thank you so much, Kevin, for having me.
All right, so tell us what led you to share this story and write this article in Kevin MD.
So it's very interesting. As you know, I'm a spine physician, a physiatrist, or interventional. So during my early years, I had this typical patient that came to see me, young, 20s, 30s, with a back problem that was not radiating, not radicular. Normally, the MRI or the X-ray were very benign. And normally, I diagnosed them on the physical examination with pain with extension and rotation. And they finally say, well, this is facetogenic pain. And I recommended to do a fluoroscopic guided injection of the facet joint. Normally, this patient did very well, allow them to do the physical therapy. And I never heard from them for years. And it was a pattern that I was very comfortable and but then as time went on, with the healthcare had changed and the insurance, they started demanding to do a median branch block before approving the facet joint. So that changed my way of handling them because I don't do the median branch block. I thought it was excessive radiation for me and the patient. So I send them to the person who does the median branch block, the other doctors. But somehow those patients were moved toward the ablation, the radiofrequency. And then what I started noticing was that these patients start to come to me, see me earlier.
Mm.
So all of a sudden I say, well, what's going on? So I start figuring this out that they were not just controlling the pain from the facet joint, but they were denervating the multifidus muscle, which is critical for spine stability. So I started doing a little bit myself because at that time the radiologists were not mentioning at all the multifidus muscle. So I started looking into that and I started noticing some fat infiltration, some atrophy of that. And so in my mind, I said, there's something going on here. So I decided to start doing a little bit of research. That's why I wrote the paper and I said, I'm not trying to badmouth radiofrequency ablation. It has a role, but the majority of the data we have is in elderly or above, over 50, where they already have degeneration. And it doesn't apply to the 20 and 30 that already have 40 years to go with a solid spine. So I made a commitment that we had to rehabilitate these patients specifically for the back, for the multifidus, which is not the typical exercise that people do when they say core. And this is something I learned now this last year when I had my prostate cancer surgery. The same principle applies with the Kegel exercise in the pelvic floor. You cannot really train, you cannot strengthen them, you can activate them. And the only way you can activate it by having some biofeedback, like with EMG surface electrodes, like I do with the pelvic floor, the same thing with the back. So it's a little more complicated than just telling the patient to go to physical therapy and do core. It's basically, it doesn't work that well. So that's why I decided to explore that a little bit more in depth.
Tell us the type of patient that would lead to facet joint injections or radiofrequency ablation, because we're talking about the younger patients in their 20s as even. Tell us the type of patients that would require that next step of treatment.
Well, the thing, what I told you before, I was used to see the 20, 30 years old that once in a year, once every 6 months, they pull their back.
Yeah.
And it was because of weakness of the ligaments, which I thought at that time, but now I think that they had a predisposition because they were not training their multifidus muscle correctly. And like I said, it's not an easy muscle to train. And I think that if you already have your built, there's a little bit more weakness in that area, then you're going to be more predisposed because you're more flexible during that time with the 20, 30 years old.
So, for those who aren't familiar with radiofrequency ablation, just tell us a little bit more about that procedure
But
and what that
basically,
is.
they depend on cauterizing, basically, the nerve that supplies the facet joint, which is the medial branch from the dorsal ramus. So the problem is, yes, you're taking the pain away from the facet joint, but at the same time, you're denervating the muscle. So now you're creating instability because, again, what I said, the multifidus muscle is the most powerful stabilizer of your back.
Hmm.
And that's what I think my theory is that because the studies that Dreyfus did in 2009, they did unilateral ablation and they saw in 2 years later atrophy and fat replacement of the multifocal, but they could not correlate with pain and disability. So there are no long-term longitudinal research to to put those two together, but I think clinically it's obvious. And what I'm excited right now, and we talk about this in the previous podcast, that the same way that AI can identify spinal stenosis very precisely, which will help me with my rehab, the same thing it can do now. There are algorithms for AI and multifocal muscle description. We call segmental measurements. And I think that my goal, Kevin, is
Mm.
that when I train these patients in 12 months, I can see a change from MRI to MRI. It's that specific right now. But again, it's a burden for the MRI, for the radiologist to do that. So I think if we just have AI narrow down to that, it will be fantastic in terms of the rehabilitation.
Tell us what are some of the risk factors young patients have to have this multifidus injury that requires even potential radiofrequency ablation? Like, how do these patients typically present, even to me as a primary care physician? Like, how would I know
But
that the multifidus was involved?
the main thing is, these are the typical patients that they have on physical exam the pain with extension and rotation, because that's basically what and there's some specific tests that you can do on the physical examination, like a prone, bringing your legs up. If you feel that the patient cannot do it and it's at 20, 30 years old, you know that there's already instability or weakness of that. But clinically, when they come to me, what they come in with back pain, non-radiating, with worse with extension and rotation, and the MRI and the X-ray very soft finding, maybe a bulging disc, maybe a little bit of arthritis. And the other thing, Kevin, by doing this for so many years, is that one of the things that I can tell you when I do the facet joint injection, I always do an arthrogram. 20, 30 years old, perfect, beautiful arthrogram. Past 50, what I do is really periarticular injection because the joint is so arthritic that you cannot keep the dye within the capsule. So I think that's also one of the things that you can differentiate as well.
Now, from the insurer perspective, what was some of the reasons they want to shift away from the facet injection towards radiofrequency ablation?
Well, I think that they meant well. That meant that they didn't want to see doctors saying, "Oh, you have a set joint injection, let's do injection," and don't go through some type of algorithm to prove that that was the case. And which I think I respect that because that will help. But unfortunately, because of the system and because or yeah, they're reimbursing very well the ablation, those patients were deviated to that to the ablation without understanding what you actually are doing. I was trained to remove the pain and I would be successful.
Mhm.
But then there are consequences that can happen 20, 30 years down the road. And I think that that's what I'm not saying that everything is from the ablation, but people who don't train, that don't properly exercise those muscles, eventually are the people who are seeing with chronic lower back pain. I have to say, I do it personally because it's not easy to train the muscle, I have to say. It's a very specific, I have to be somebody who knows what they're doing. We tend to, I remember for many years, do core. Oh, go and exercise without being very methodical about what are we trying to accomplish.
So, in terms of those complications from radiofrequency ablation in younger patients, 20, 30, 40 years down the road, is it chronic back pain? Like, how does those
Yes,
complications present?
chronic back pain, dysfunction, weakness, and it's a snowball effect. They stop doing what they were used because now my back hurts. I'm getting old. It's not functioning, and it's funny. It's just I think that it inevitably is going to happen at the end of the life. I think that one of the problems, and this is a way I'm so passionate about this, Kevin, is that we need to try ourselves, no matter our age, as an athlete, and that's the way they were treating an athlete. To avoid the chronicity of back pain, they're going to be very specific. They're going to do surface EMG to know that you're activating the muscle and start seeing now with the MRI, see the changes. Like I said, like for example, if I see a patient that comes in with back pain and I do the MRI and the multifidus is already atrophy or replaced by fat, you say, well, that's from arthritis, or it was from an initial injury or from the lack of exercise that is what's happening. So now there's a way of quantifying what's going on with this. And if unfortunately a 20-year-old goes for an RFA ablation, then I can see if it was really caused by the ablation because hopefully a 20-year-old has a healthy multifidus to begin with. If we see atrophy later on, then we know it was induced by the ablation. And then the other thing, Kevin, is that we have this mentality that to take away the pain. But imagine if we do ablation for shoulder pain. We're going to ablate the suprascapular nerve, and now we're going to have no pain, but instability of the shoulder and arthritis developing. So in that mentality of burning and doing ablation, you can do it for, they're doing it for the knee. Unfortunately, they're not causing too much muscle atrophy, but if you do it for the shoulder, for the hip, I think you're going to see some of those changes eventually. So it applies to other structures in your body.
So tell us the type of conversations that you're having in your exam room for someone that you suspect that has a multifidus injury, and you're talking about the various treatment options. When radiofrequency becomes discussed, do
Yeah.
you go through all these potential complications with the patient in front of you?
But that was part of the article, Kevin. I think part of the consent form, and I do that with my patients, is I explain to them that it's not only they're eliminating the pain, but they are denervating a muscle that is very important for their back. And I think that part should be part of the consent form. And I don't think that is being told to their patient upfront. Because many times when I tell that to the patient, they say, no, I'm not doing that.
Yeah.
So I think that if we don't say that to them and they don't know, I think they can come back after you and say, "But okay, you took the pain away, but now I have a weakness. I have all this muscle instability and all that." So I really think that should be part of the patient have to agree to have their muscle denervated. I think that should be part of the consent form. That's my opinion.
So if radiofrequency ablation doesn't fit those young patients, you mentioned specific exercises
Yeah.
and facet injections as potential options. How effective are they in terms of removing multifidus related pain?
Well, because then when we talk about multifidus, remember it's the main source that it's really the pain comes from the facet joint.
Hmm.
The multifidus can be unstable or weak and causing, but really the source is the facet joint. So that's why many years that I did this in the past, I was blocking the facet joint, helping that inflammation to be under control to allow them to train and then resume their life, but also with the exercise as part of their life. So what I'm saying is that many cases, maybe you don't need to do the ablation and you can do just the rehab and recover. But if we have the tool of the steroid injection and control the pain, then we'll be able to maybe minimize the damage. And I can give you an example. My son, 21 years old, several years ago, he had back pain.
Hmm.
Typical. He went through all the treatment, but then he got confronted about doing the median branch block before the facet joint. I said, you know what? It's not worth it. So he went and at the end, he finished up with, regenerative injection therapy, completely cured, fine. And he was heading in that direction because they're already talking about ablation. So just an example of somebody who probably suffer later on 30, 40 years down the road with chronic back pain.
So, for the patients who may be listening to you in this podcast and they're in a situation where they're offered radio frequency ablation, tell us the type of questions those patients should be asking their physicians before undergoing that procedure.
I think, and I don't know because I know too much, I would say, are you measuring the size and the quality of my multifidus muscle before you do it? Can I have a baseline? Can we repeat the MRI after training? Are you going to send me to a specific physical therapy that have way of measuring the activity of the muscle to train them? So I would just be sure that we have a plan. Again, it goes back to the same thing with the pelvic floor. The data show that if you start the exercises 6 weeks before the procedure, you're much better off. So I think that the same principle applies here. See, the thing with if we do a facet with a steroid, there's no harm. You're just reducing the swelling. That's just no harm. But once you do the ablation, there's going to be an anatomical change, and that's one of the things I tell my patient. We're destroying here. It's not benign procedure. You're actually changing the anatomy. With the steroid, you're not changing the anatomy, so it's a little more comfortable in their mind. So that's basically what I would definitely MRI guided the MRI evaluation of the multifidus and a follow up with that.
We're talking to Francisco Torres. He's an interventional physiatrist. Today's Kevin MD article is radiofrequency ablation and a young back pain patient. Francisco, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Well, I think that we as a doctor, we should not let us dictate our management or our treatment based on an algorithm that pay your bill. You need to question what you're doing. And if you decide to go in that route, the patient needs to be consented, be specifically told. And I think the physical therapy should not be generic. This condition, if we start treating them when they're 20, 30, we're probably going to save them their back from chronic pain.
Francisco, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thank you, Kevin. Appreciate it.